So welcome everyone. Thanks for joining Leona and myself on this wonderful evening. I know you probably weren't going to have a walk this evening in that terrible weather, but welcome rain. We've been praying for it, and aren't we so happy now that it's here?
Yes, yes.
So the topic today is the patient-doctor relationship and making the most of every medical visit, whether or not you have a family doctor at this time or not. And a lot of the tips you can apply to any medical encounter, particularly useful if if you have to go to a walk-in clinic, if you're going to the emergency where you're not familiar with the healthcare provider that's meeting with you and looking after your needs, or if you're traveling somewhere, there's some key questions that you should be asking and key information that you need to know so that you can make informed decisions, because we're really there to support you and make sure that we give you the information and the support you need to look after yourself. So there's a handout, a key points handout that is available on the website. Leona, are you going to be able to put it on the chat as well?
Yes, absolutely.
Okay, that's great. So it's kind of a good cheat sheet to carry with you. It also includes just a summary of the key things you should know from your own medical history that you should carry around with you, even when you're in town and not going anywhere else, in case you go to the Emerge. Just those key things that any healthcare provider needs to know to give you proper care. Things that you just want to have at your fingertips. So just like a one-page summary of your medical history and a summary of your medications. So I'm hopeful that even if you've been to some of our talks before, that you'll find some useful tips that be practical for yourself and that you can share with your loved ones. So that's my hope and I wish for all of you that you'll get something out of it. And that if you do share it with people that matter to you so that we can share good health for our community. I want to briefly turn things over to Leona and also thank Leona for organizing our Empowering Patients talks over so many years. I think it feels like 8 years. To me, it feels like 8 years.
Something like
Originally
that.
in person, but 3 years virtually during the pandemic. So I'll turn things over to Leona because she has some wonderful resources about available resources in the Burnaby community and also resources for those of you that are looking for a family doctor. So the links will be in the chat, but I'll let Leona highlight that for us.
Great. Well, thank you everybody for joining us, and thank you, Dr. Wong, for always making time to support and actually put this the program together, because it's very important. It's great information, and I'm really proud to be a part of it. Resources, as Dr. Wong said, I've already posted a link to the other resources page, which will give you all of the key points, documents, and presentations from our last few talks. So the one for this evening is already there for you. I'm also going to post our Empowering Patients page, which has a list of and registration links for all of our upcoming talks. So please register for any that you're interested in. And at the bottom of that page, if you scroll down, there's recordings of the talks that we've done previously. So you'll see that there's some duplication of topics, but Dr. Wong always updates the information. So if we've done a talk on diabetes before, Dr. Wong always takes the time to update and make sure that you're receiving the most current information that's out there. I'm also going to share a link to our Looking for a Family Doctor in Burnaby page. I know Dr. Wong's going to speak to that tonight, but we do have a non-urgent patient attachment program. And so on the page that I'm going to share gives you a summary of our program and a link to a secure form that you would fill out to get yourself added to a wait list. So if you're looking for a family doctor in Burnaby and you're a Burnaby resident, please feel free to complete that link. I'm also going to share our Primary Care Network's main page. Primary Care Networks, or PCNs, what we call it, is just many programs that have been developed by the Burnaby Division along with Fraser Health and community partners. So there's many supports out there now for seniors, youth, many things. So I'll share a page with that. Please take the time to go through it and see what's available. And as Dr. Wong said, share it with people you care about. We do have a doc talk. So it's a similar program to the Empowering Patients program, this one, but it's done by other physicians in the community. So we're doing one on October 28th, and that is understanding the COVID-19 boosters. So if you have lots of questions, which many people do, please feel free to register for that, that event, and that link will be in the chat. And finally, on November 3rd, we're hosting an Everyone is Welcome event. It's a Burnaby Community Celebration event. Anyone is welcome. I'm going to put the link with the information about the event in the chat. It's half day at the Ismaili Center, and we'd love to see you there. I'm going to be there too. So I'm going to start putting those links in, and I'm going to turn it over to Dr. Wong.
Thanks, Leona. So you might be able to tell that Leona and myself are recovering from a cold, non-COVID upper respiratory infection. I had mine 10 days ago, so I'm pretty well, totally recovered. Sounds like Leona just had it in the past week. So because a lot of us haven't had a cold for 3 years, wearing masks and hand sanitizing, so that first cold after the start of the pandemic, everyone, male or female, even if they're really tough, is getting a man cold. You know, where a little cold that's usually better in 3 or 4 days makes us a little miserable and coughing and stuffy. So keep on washing your hands and being careful in indoor spaces. I still encourage you to wear masks, preferably N95s with kind of crowded social gatherings or being around people that you don't know personally that could get you infected. And that will also protect you against COVID, the new rapidly spreading variants. At the end of the talk, we'll leave room for your questions. So you can post your questions in the chat, and Leona will help guide me through those questions. And they could be related to this talk, any questions you might have about relating and communicating with healthcare providers, or any general questions, including questions about COVID or COVID vaccines. And if you have further questions, I encourage you to attend Dr. Sangara's talk. He's a friend and colleague. We work in the same office. We founded Prime Care Medical together with 2 of our colleagues, and he's a very good speaker and very well informed on the topic of vaccinations and COVID. So this is brought to you by the Burnaby Division of Family Practice. Many of you are familiar with the division already. It's a nonprofit association of the family doctors that serve the Burnaby community. So I've been really fortunate to be working with Leona since the founding of the division. I was the founding chair and medical lead, and just left the board a few years ago. I think it's been 3 years, but I continue being active with the community, and especially my favorite, Empowering Patients, which is a non-profit, unbiased public health education, because so much of the information that you get on healthcare is biased or not reliable. So what you see on TV and the news is often kind of slanted towards someone trying to sell you something. So I'm not trying to get more patients because my practice is full, and I'm not selling any products or books or anything, but I'm trying to sell good health and really empowering you to achieve your life goals. So that's our role as healthcare providers. To learn more about the Burnaby Division of Family Practice, and of course our Empowering Patients program, our website is listed here, divisionsbc.ca/Burnaby, and it's also in the chat on that key points handout as well. So why are we here? A big, deep question. I actually was born in Vancouver, but grew up in Burnaby. And when I was 11 years old, I was in Burnaby Hospital pediatric ward for 2 weeks with systemic vasculitis, which was an autoimmune condition related to my rheumatoid arthritis. And it was very uncomfortable with aches everywhere, fevers, chills, and head to toe rashes. So I was very sick, but I was really comforted by the really caring nurses and doctors that looked after me. And they treated me like a whole person, like a kid, and they weren't treating disease. So I felt that I want to do something like that, to develop some professional expertise so that I can help people in need and know that they are treated as whole human beings. And my family doctor, Dr. Dan McCarthy, visited me at the hospital when I was there as well. And that's comforting to have that long relationship over time with a family doctor that I trusted. So he is a great role model for me. And I was really fortunate to get into medical school at UBC, and I chose family practice, or rather it chose me, because I really felt that was my calling. So as family doctors, we care about our patients and we care about our community. And I think that really shows in all the things the Burnaby family doctors are doing for the health of the whole community, like improving the care of the homeless, the disadvantaged, the people that don't have a family doctor, working with all of the partners, including the Health Authority and the many nonprofits and charitable organizations and the city of Burnaby and the school board, all working together, Parks and Rec, everyone working together to support our community. And together, all of us in this room virtually are here to support one another, our neighbors, our families, our communities, and really our future. So again, I'd like you to share anything you find useful in any of these talks with the people that you care about, your neighbors, your loved ones, and anyone you can reach out and help. So again, we care about our patients, but we care about our community as well. Every one of my talks starts with, what is healthcare? And a lot of people think about the acute care in the hospital that we see on Grey's Anatomy, but family docs and community nurses will talk about community care and chronic disease management, which is the bulk of the care that we give you in the community. But really, who is the individual that provides most of your health care? And here's a hint, it's not your family doctor, it's you. So we as your family doctors are here to support you, to be your coach, your partner, your mentor, and helping you achieve your goals. So real healthcare is self-care. So the best predictor of your future health, with those things that are under our control, are the habits we practice every day. So as a little framework for our talks, I always talk about the 4 foundations of self-care, how you look after yourself. It includes what you eat or what you put into your body, good and bad stuff like drugs or cigarettes, alcohol, recreational drugs. But mainly we give tips on healthy eating, how to support your body. So that's one of the big topics that you can find in our archives, including a video on healthy eating. We recently gave a talk on physical activity, healthy physical activity, so what you do. And the 3rd foundation is emotional well-being, how you feel. And then finally, how we connect, healthy relationships. So these are big foundational topics that you'll find in the archives, and we'll include many of them in the upcoming year on our schedule. So 4 foundations of self-care, how we look after ourselves, what you eat, what you do, how you feel, and how you connect. And to be an empowered patient, someone that's in control of your health, what do you need? You need some support, information to adopt healthier lifestyles, to manage health conditions, chronic and acute, and information about how to get the care you need, how to access that care. And you need that support to achieve your personal goals. And we do need to improve patient-doctor, patient healthcare provider communication, because there are a lot of barriers that we'll be talking about. And we'll be talking about some solutions how we can smooth things out and help you get the care that you need, whether or not you have a family doctor. So the relationships between a patient and their doctors are very just like our relationships in marriage and our friendships. So infinite varieties, everyone is unique, but we all have one common calling as physicians, your well-being. So the first rule in medicine, right after do no harm, is to put the patient first, put the patient's needs above our own. But of course, doctors have their personalities, including myself. So doctors are people too, imperfect with our own quirks and quacks. And my prompt to remind me of one colleague that has a lot of quirks, one of my office colleagues. He really cares for his patients like I do, but he has a few quirks. So today is, we declare it as Food Security Day, because you can safely put your lunch in the fridge and have faith that by lunchtime when you're hungry, your lunch is still there. So we have one colleague that is kind of a kleptomaniac in the kitchen and has been known to eat other people's food. So we're all different, but we all care in our own special ways. Of course, doctors get stressed. So you probably heard a lot in the media about physician burnout and that there's a shortage of family doctors, largely because established doctors are getting burnt out, retiring early, moving away, going into something to narrow their practice so they're not doing full scope family practice anymore. And that's a big tragedy because primary care, what the family doctor does as your advocate and guiding you through the healthcare system, is irreplaceable. There's no one that can do the same thing. In a moment, I'll explain what's really unique about your family physician and the role that he or she plays. So we get stressed when we're running behind, just like patients get stressed if they have to wait a long time. Some patients are angry. I don't encounter too many, but often with walk-in clinics where you're not really familiar with the patient, patients tend to vent out their anger, their frustrations with the system or with long waits as well. The cases that we manage are more complex in the family practice office than you would encounter in most walk-in clinics, because patients, over time, they have chronic conditions, but you actually manage more than one or two things at a time. Sometimes patients are very sick, and that can take up a lot more time than the time allotted, the 10 or 15 minutes that's scheduled. It might turn into 45 minutes or an hour in some cases, and we can't always predict. And of course, doctors are human too. If it's kind of a truism that doctors will continue to function very well at work while the rest of their life is deteriorating. So that doctors will allow their relationships, their home life, their physical health to suffer long before there'll be any compromise in the care that they give their patients. So that's good for patients, but it's not good for the doctors and their health, and not good for the long term for family practice and medicine in general. And you probably aren't aware of the scope and the amount of time that goes into the work that we do behind the scenes when you're not in the office. That's a lot of our hours completing forms, writing medical legal letters, applying for drug coverage, reviewing test results, consultation letters, and following up on patients that with abnormal results or that we need to follow up on. So that actually consumes a huge amount of time, and I'll give you an idea of what that's like later on in the talk. And the non-face-to-face work, what we call the administrative burden that you might have heard in the media, has astronomically increased since I started practice 31 years ago. So when I started practice, I was at Kingsway and Nelson by the London Drugs. So it was on the 6th floor of that 4980 Kingsway, same building as the Life Labs, which used to be BC Bio, which was on the 2nd floor, and on the main floor was Brooke Radiology. So pretty well almost all the lab results and the x-ray results would come to me by paper, the same days that they were done, actually. So it's actually faster than we get them now with electronic medical record, because I happen to be in the same building. So I would get a pile of results that I was able to actually go through, and this was before computers, so it's actually even faster. And for abnormal results, then I could make a notation, ask my medical office assistant to give me the chart, and then write down directions if the patient needs to come in, or if I should call the patient, or it could be filed in the chart. So it would just take seconds most of the time to get through that bit of the charting and reviewing tasks. And I would be able to do most of that within 15 minutes. There'd be a little extra time to write referral letters to specialists, to fill out forms for investigations. And there weren't that many forms for disability or time off work at that time. So I'd be pretty well wrapped up, unless there was some medical legal report that I would need to take home in the evening or at nighttime. And it was encouraged that doctors don't remove charts from the office at that time. That was one of the College of Physician Surgeons recommendations. So we generally tried to do all that we could in the office hours. And at that time, 31 years ago, up to about 20 years ago, it was actually quite manageable that I'd be home for dinner. done with the day and not having a lot of paperwork, and I could enjoy the evening with my family. So today is totally different. It's a minimum 2.5 to 3 hours after I'm done at the day with the day. So finish seeing patients by 6 o'clock, usually at the latest on the usual day, unless I need to fit extra people in or doing a flu shot clinic. But it's working on the computer, either staying later at the office for a couple of hours and coming home late for dinner, or bringing home my computer. We don't bring home the charts, but we bring home the computer that where the tasks kind of follow us. And I can get 100, 150 new tasks in my inbox of my computer every single day. And some of them would be patient came in for an electrocardiogram done. So that would be one task. Electrocardiogram sent to cardiologist. That's another task that I have to open up and then deal with. And then finally, the electrocardiogram when it comes back, the actual report. So instead of looking at one piece of paper when it's done, it's actually going and opening little boxes over and over again. So you can imagine how time consuming that is. So the electronic medical record has been great for providing excellent care to patients, ensuring good follow-up, organizing our charts, being able to look after all our diabetes, high blood pressure patients, and make sure that they're coming in often enough and doing their lab tests. But it's been a real psychological burden for physicians and very time consuming. So about 40% or more of my time, a 70-hour work week, working Monday to Friday, is actually doing these extra tasks, minimum 2 to 3 hours every night, and average about 8 hours every weekend that I have to carve out to get these tasks done. So you can see why young doctors who can go into family practice, do full service family practice, are choosing not to do that because that's essentially unpaid work. We get paid per visit. So as I'll show later, that we get paid the same, $30 to $40, depending on the patient's age for a regular visit. The walk-in clinic doctor that gives you a prescription for a urinary tract infection or renews your blood pressure medication when you walk in under 5 minutes gets paid the same as if I spend 20, 30 minutes with a patient working through a number of complex problems, the very same. And then after that visit, there'll be a number of minutes, 15, 30 minutes, where I might be doing other things related to that patient's visit, but outside of the office hours. But I became a family physician because that's my calling, as I mentioned, because I wanted to treat the whole person, not just a particular system or just a medical problem one at a time. So this is a sign that my patients never see unless they're in on this webinar. This is my medical office assistant, who is Christina. And on Fridays, it's my niece. So be extra nice to my medical office assistant. My patients are out there on Fridays, because that's Helen. Helen is my niece who just graduated from high school and is going to SFU. So she's been trained by Christina, so she works on the Fridays. So this is what they see looking out the window towards my patients when they come, a little sign that reminds them that we treat every patient as a friend or family member. So with the same degree of care that we would want for any of our best friends or our loved ones and family members. So sending them to the same specialists, prescribe the same medications, getting investigations done as quickly as we would want for ourselves or for our loved ones. So we treat every one of our patients that way. So it takes a lot of effort, but then you sleep better at night knowing that you're doing your very best for every one of your patients. But that's a little secret. So you don't have to share that with everyone, but that just goes to show that it's a different relationship with your family doctor, with each of their patients, as it might be with a doctor that has only seen you a few times. So there's some differences between family practice and other specialties. So I actually have these as signs that I wrote and put up. So this is in the lunchroom at our office where our medical office assistants and the physicians see. It's up high up on the wall above the bulletin boards that I put together. In family practice, we don't treat disease, we care for the whole person. And family practice is unique among any specialty Again, because we treat the whole person, not just conditions or parts of the body. And as family doctors, we advocate for our patients to meet the challenges of their lives and to negotiate the healthcare system. You really need a guide that knows how to access the care and who the appropriate specialist might be for you to see. And you've heard about longitudinal care. So longitudinal care, as most people understand it in primary care, is having a relationship and follow up over time, be it months to years. And there's a lot of encouragement to have team-based care where multiple healthcare providers are working together to look after you, but the key is this longitudinal record. But I really believe that family practice includes that, but it's much more than that as well. So I say it's latitudinal as well as longitudinal. And by latitudinal, I mean family practice has depth. Our care is really informed by our individual patient's experience. And family practice has breadth. We understand the patient's situation in the context of their whole life. All the other priorities that they have, including their family, their work, and their other passions and their goals in life as well. And again, longitudinal. We're building trust in a relationship over a lifetime. And I think our patients really appreciate that personal care and that relationship over time. And in family practice, we empower our patients to transform their problems into goals. So even though people bring problems to the office, I like to move my patients towards moving towards their goals, knowing what matters to them, and trying to turn their problems into goals. So when someone comes in with stress or anxiety, I often ask them to kind of visualize or look at what our goal would be. And it's not just the absence of anxiety, but feeling calm and collected and in control of your life. So we try to empower our patients that way. And then we'll give some tips at the end on how to set really smart goals that are more achievable. So much of medicine is reactive and focused on just symptoms or problems as they pop out, but we try to be more proactive and looking at your whole health. And that's the advantage of seeing your family doctor. And that's why many patients, after going to a walk-in clinic or emergency or a specialist, will end up coming back to their family doctor and asking for their advice before they decide to do a particular investigation or operation or even take a particular medication. Our relationships have changed during the pandemic because a lot of what we do now is by telephone or virtual. I understand there's still some family docs out there that aren't seeing patients in person, but we really have to, it's not sufficient to see someone just virtually for many different conditions. So this has transformed. And I think telehealth, either video or phone, they have benefits as well as limitations. I think you'll continue to see telephone or video visits in the future. There's a lot of corporate medicine that aren't really invested in primary care or your long-term health that are trying to take advantage of the fee codes that allow for phone or video visits. So they don't know your family history and they're not invested in your long-term health, but they get paid the same as your family doctor who knows you well for treating one problem, even though we're treating multiple problems. So if you are able to access your family doctor by video, by phone, or in person, do reach out to your family doctor first because you will get better care. But I do understand talking to other people that sometimes they've had difficulty kind of accessing their offices with their family doctor as well. So I understand there are some limitations. I've discovered with telehealth, there's a lot of things that you would think you can diagnose by video, telephone, or photos or email that are actually sometimes very difficult. Like a rash, you'd think if you had a very good image of a rash, you can diagnose it. So much of the time we can, much of the time we can't with certainty. It's sometimes better to see that rash in person to be able to measure it ourselves, to look for other signs of disease that might be associated with that rash that the patient might not be aware of. Videos have been really terrible for seeing really clear images of the skin. And photos, if they're taken really close up, it's really hard to get the context of what part of the body it's of. So I've had some challenges being certain about some skin rashes, and often will have the patients actually come in so I can examine it in person. Now, telehealth has been great for treating some of my patients that moved to Vancouver Island or the Okanagan, or that live quite a distance, like more than 45 minutes away. It's really helpful for them to be able to talk about things or to chat by video to look at some things that we can manage. But typically musculoskeletal injuries like back pain, they're best examined in person. I had a patient that moved to Armstrong. She could not access any care in any walk-in clinic after her car accident. I was relying on her description, videos, photos, the description by her physiotherapist on what her problem was. So after 4 months, she was able to come in, and I was able to do a hands-on exam and find out that her back pain was actually related to the alignment of her pelvis. And I was able to show her how to realign her pelvis with appropriate exercises, which caused a significant improvement. But it just goes to show, without that hands-on visit, you can waste a lot of the patient's time and a lot of video and phone visits without really getting the core getting better. So there really is no substitute for an in-person visit where we can use all of our senses and our stethoscopes and a careful examination. So really miss that part of practice. So it's kind of half and half. Some days I might see 80% in person, some days it's 50% by phone. So COVID vaccinations, information overload. It's great that Dr. Sangera, my partner at work, Baldev, is giving that talk. He's very well informed. He's been up to date and being right on top of things, and a great community advocate as well. So as you know, now have the bivalent vaccines, and there's two to choose from if you're due for your booster. So there's the Moderna, which has part of it is the original vaccine strain, the Delta variant that was at the beginning of the pandemic. And the other part that makes it a bivalent is one of the early Omicron subvariants. So the Moderna vaccine, bivalent vaccine, has BA1, the first subvariant of Omicron that came out in November, January time, around Christmas time last year. The current variants that are affecting 94% of current infections are BA4 and 5, mainly BA5, which are more contagious. And it's the Pfizer bivalent vaccine that is targeted to the Delta, the original Omicron variant, in addition to BA4 and 5, the new Omicron subvariants. So that's the most up-to-date vaccine. There haven't been head-to-test checks to see if one works better than the other, but the very latest is the Pfizer bivalent vaccine. And I haven't seen a big increase in side effects or problems with it while they've been out over the past month. The Pfizer vaccine was just approved a couple of weeks ago, but it's been in the US almost as long as the Moderna vaccine, which has been out for about 6 weeks. So those are the ones that are available, the main ones that you have a choice of when you go to the pharmacy for your COVID vaccinations. It's also flu shot season, and your family doctor's office probably has flu shots available. There's kind of limited supply for those as well. They haven't gotten all the higher potency shots that the flu ad that should be available for people 65 and over. So that hasn't been supplied to a lot of pharmacies or family doctor's offices yet. And masks, we're getting used to wearing masks. You still need to wear a medical mask in a medical clinic or office. And just as a reminder, these surgical masks are not very effective against the COVID-19 viruses, including the latest subvariants. You're better with an N95 or KN95, the high filtration masks. I'll tell you a little secret. If you want to get a very inexpensive KN95 mask that fits really well, Summit Tools is a hardware store in Burnaby that has them really cheap, like 20 masks for $8. So that's a little secret. Don't tell everyone, but if you want to get a better quality mask that's not expensive, then they do have it at Summit Tools. So the KN95 masks. So the challenges in the patient-doctor relationship, I divide that into number one, access, finding your family doctor or waiting for an appointment. Number two is time, like running on time. So many problems, so little time. Three is sometimes the language that we use is just, sometimes we can get stuck in our jargon, our med speak or medicalese. And also the instructions, what you go away with, what the doctor and the patient agreed to going out. What we used to call doctor's orders, but I know that doctor's orders are not always followed. So I've changed that into the patient's goals, something that we negotiate and talk over, and what you can do to increase your success in achieving your goals. We'll talk about that at the end. So first of all, access and finding a family doctor. So as you know, 1 in 5 British Columbians who wants a family doctor does not have a family doctor. And it's even worse in some communities. It's much worse on Vancouver Island. Burnaby has been working really hard since we founded the division pretty close to 10 years ago in trying to attract new doctors. So Burnaby has been pretty successful in attracting new doctors to family practice. And we do have some new doctors that have come in the past year and more to come. But the number of the thousands of people that are looking for a family doctor is a bit overwhelming. So the wait time is about 12 to 18 months to get connected with a family doctor. But you should get on the list. So if you live in the Burnaby community, contact the Burnaby Division of Family Practice. If you're in Vancouver or Surrey or New West, then you should contact for New West, the Fraser Northwest. There's a Surrey Division of Family Practice, and there's a Vancouver Division of Family Practice. All of them are doing their best to attract new doctors and to connect what we call attached patients to a primary care healthcare provider or family doctor. So if you're looking for Burnaby, check our website with the link that Leona has provided. So why do you have to wait at the doctor's office? Our office is usually pretty good at running on time. So there's some practices that run behind because the doctor actually arrives half an hour late every day. So I've heard of personal friends and family members where that's the case, but that's not the case at our office. I start on time and I try to stay on time, but there are things that are mainly beyond our control. Patients are complex and they have multiple complex problems. We have constant interruptions. So a lot of patients are going to the pharmacy trying to renew medications, but renewals have expired. So we get many faxes from the pharmacy, on average about at least 10 a day, and worse on Mondays. So when I'm renewing a prescription, I have to actually go through the chart. Like if it's for a thyroid medication, I have to check when they last did their thyroid blood test to make sure this isn't just renewal where the thyroid dose should be increased or decreased. If it's for high blood pressure, then I have to make sure that we check their blood pressure recently or that they've been monitoring it. So sometimes we won't always renew, or we might do a shorter renewal if we need to call the patient in to recheck or do a physical exam or review their medications. We also get calls from the hospital. If a doctor is doing palliative care, we might get calls from the hospice or from a nursing home. And sometimes the pharmacy itself will call for just some clarification with medications. So these are kind of unscheduled interruptions that can happen randomly throughout the day. And it could set us off by 15 minutes or longer, particularly if there's an emergency. And actually in our office, one of our colleagues had to call the ambulance because a patient was getting acute chest pain that could have been a heart attack. So that was a big interruption to my colleague's schedule this morning. And sometimes a patient, something has suddenly happened. They might be coming in for another reason, but their loved one died and they're suffering from grief. And we can't give them the support they need in just a short visit. So we might spend a lot of extra time with them, and because it's so hard to turn away someone that's really in need at that time. So many different reasons, things that we have to respond to. And that's why the wait can be increased that way. So it's the nature of our work. We're all human beings coming in and treating human beings. Health and disease are all infinitely complex, and things are always changing and unpredictable. But we do try to kind of organize the schedules that we can I schedule 5 patients per hour. So kind of averaging 10 minutes, unless it requires a physical or a counseling visit. And that gives a little bit of extra time so that if some go over, then we can accommodate for that too. So the list to physicians can be a 4-letter word. So with every problem or symptom that you bring into your doctor needs to do a number of things. So if you're coming in with some abdominal pain, that could be gallbladder, appendicitis, diverticulitis, or colon cancer, or an ulcer. It could be many, many different things. So we actually have to listen very carefully to your symptoms and how you describe it. And we ask quite appropriate, clinically important questions like, what's the nature of the pain? When did it start? How frequently are you getting? What makes it better? What makes it worse? And also knowing whether there's some family history of particular conditions. So we ask these key questions so that we can kind of work out what the diagnosis might be. And with all those relevant positive or negative responses to questions, we actually have to document that in the medical chart. So you'll see us typing on the computer at the same time, but sometimes we have to add in more after you leave the office just to make sure we got all the information put together. So that's taking that careful history for each problem that you bring. And we also have to perform an appropriate physical examination and document the relevant positive and negative findings. So when I'm doing an abdominal exam, I'm palpating, feeling the abdomen in particular areas, looking for particular signs, making sure I don't feel any masses or lumps, and noting where the tenderness is. And there's particular signs that we check to see if it could be gallbladder. We call that the Murphy's sign, when we tuck our fingers underneath the ribs and ask you to take a big breath. So if there's a particular type of catching of your breath or pain that suggests that it might be gallstones or inflammation of the gallbladder. We actually even see if the liver or the spleen are enlarged. We feel to make sure the kidneys are not enlarged or tender. We check a particular spot, the right lower abdomen, for possible appendicitis. And we're able to check for a variety of other things like hernias just by a careful physical exam. Definitely nothing, it's not something you can do on yourself, and not what you can do virtually on a video or telephone call. We also listen with our stethoscope, listening for sounds of abnormal blood flow, what we call bruits, or abnormal bowel sounds, or the absence of bowel sounds, which could be a bowel obstruction. And we actually observe a few things that you may not notice. We look at skin color to make sure you're not jaundiced, where it could be a liver or pancreatic problem. So there's a lot into the physical exam that we need to detail in the chart as well. And then finally, during all this time, the doctor is thinking, even though he's trying to listen and paying attention, and formulating what we call a differential diagnosis, because there could be an obvious thing it could be, but there also could be really other important things that these symptoms might indicate. So we always come up with a list in our brain of different things it could be, and based on our physical findings, your responses to the questions, or further investigations, we're able to narrow it down what it most likely is and to rule out other conditions that might be particularly important. We're always thinking as doctors, what's the worst thing it could be? So making sure that it's not a heart attack or a possible stroke, or make sure that there's no chance that this could be cancer, what we do need to do to eliminate that concern. And then finally, we want to formulate and communicate a plan for managing your problem. And this is for every problem that you present. So what should we do for further investigation to rule something out or to clarify what the diagnosis is? And do we recommend some physical therapy or exercise or medication or referral to a particular specialist for a particular condition? So all of this takes time, and we need to kind of clarify the risks and benefits of different types of investigations and management or medications that we're prescribing. And I'll go over a bit later about kind of those details you need to know about every investigation and drug. So those key questions that the doctor must answer for you in order for you to make an informed decision. So that's a lot of complex brain activity that your doctor goes through just to manage one single problem. And the majority of the patients that are coming through the door actually have more than one problem, not uncommonly two or three. So all this that their family doctor is trying to cover in just one visit. And of course, we need to translate that information into plain English to ensure that we both understand and to make sure that you're giving your full consent. You have enough information and you know the alternatives that are available. And with every problem or symptom that you bring to your doctor is also spending some time after you leave the office. So it might seem like a 10, 15, 20-minute visit, but there's actually more time your doctor is spending on your problem and your health in general. So we need to look up the most appropriate specialist for the referral. So we have a website called Pathways where we can see who is available, what their wait times are like, and what their particular subspecialty is, and what they're interested in seeing. And even with that, although it's quite up to date, we get a lot of referral rejections because the specialist has really subspecialized further and doesn't treat certain conditions. For each of those referrals, we have to write a referral letter. So telling them what the problem is, what the history is that we've related, and also the investigations we have. And we attach the important lab investigations and other appropriate consultations to that letter so that the specialist has all the information they need about your past history and your current symptoms and the investigation so that they can go forward and help you solve the problem. We also have to complete detailed referral forms for every investigation, as simple as a chest x-ray or a CT scan or MRI. It actually takes a few minutes to actually fill those out and write the relevant details. We also are writing notes, letters, and completing forms for time off work, and even takes more time to fill out a disability form for an insurance company. And it does take time to send the prescriptions to the pharmacy and completing lab requisitions. And we also have to ensure that each visit note is completed according to the strict standards of the College of Physicians and Surgeons, really outlining all those steps that I mentioned, what the doctor is doing with you when you're in the office for every one of the problems that you bring in. Even if you bring in 4 or 5, your doctor is taking some time to make sure that he has noted all those important things, because those are really important for the electronic medical record, the chart record. It has always been that way, including paper and electronic charts. And your doctor also goes through the rest of your chart to ensure that you're up to date with appropriate screening tests based on your personal history, your age, your gender, and your family history, so that we're not just reacting to the problems you're bringing to us, but also making sure we're doing proactive care to make sure your colonoscopy is up to date, if you have a history of polyps or a family history of colon cancer, to make sure your mammograms are up to date and your pap smears are up to date as well. So all these clinical processes take a lot of time and tremendous mental effort. So many of us at the end of the day are quite mentally fatigued. We can't even choose what to watch on Netflix if we want to, because we're just mentally tired of making too many decisions. So we usually leave it to our spouses to pick the movie to watch at home that night while we're doing our tasks on the computer. So can you imagine what it's like to manage multiple, often complex problems in one visit? Your family doctor requires much more time and effort. As I mentioned, is paid the same for that visit, no matter how many problems or how much time he takes or how much time afterwards, as the walk-in clinic doctor who treats a single simple problem, or the TELUS Health doctor that treats your problem by telephone or video, a one-timer, paid the same amount that your family doctor gets paid for doing all this extra work on your behalf. So on behalf of your family doctor, I'm asking you, please don't save up multiple complex problems over a year and expect your family doctor to manage all of them at one visit. You should be upfront with all your concerns with the staff and your physician, and then kind of create a schedule how you'll approach them and deal with them to make sure everything is addressed. But not to expect it can be done in a single visit. And please don't surprise your doctor with an extra problem at the end of the visit, like going out the door, like the by the way. Even if it seems simple to you, like a little lump or a mole or something else on your skin you want to check. Because if you add that on at the end of the list, at the end of the visit, knowing the doctor has to document every detail, so he needs time to do that. And if you put it at the end, it makes it really, really hard. And your doctor's going to have to ask, how long have you noticed it? How has it changed? What have you used for it already? In addition to examining it, measuring it, writing a detailed note, and talking about how to manage it, when to follow up. So that takes a tremendous amount of time. So you might think you're saving the healthcare system. So I've heard patients say that before. I'd like to save the system money, so that's why I'm not back for 5 years, but here's my list of 20 things that I'd like to go over. So you're not really saving the healthcare system or a lot of dollars. You're actually forcing your family doctor to rush through your problems, making the rest of the patients the day wait a lot of extra time, but also contributing to your doctor's burnout. Because if he or she wants to be nice and tries to manage all your problems at one visit, either he won't do a good job or he could do a great job, but he's going to be mentally exhausted and be rushed with the rest of the patients for the day. So my colleague, Dr. Barr, and I were just thinking, this is kind of how we feel when sometimes during the, actually pretty well every day, there'll be patients that kind of bring in 5 problems and then they add on another one. And it's just so much to manage. So we do the silent scream inside. You never hear anyone screaming in the doctor's office. Well, not in our office, but this is sometimes how we feel. Well, not sometimes, but a couple times every day. And at the end of the day, if we've just been kind of burnt out and dealing with so many complex problems, usually by the afternoon, we're kind of feeling like this. So some keys you can do to get your needs looked after is really, really important to share that list. So the list is not a 4-letter word, but it's something really to be open and to share with. So when you're making an appointment, make a list of your concerns and share everything on that list with your medical office assistant that you're calling. So share it with the staff when you make the appointment so they can schedule appropriate time. And it might require more than one visit, so be aware of that. And reviewing that list at the beginning of your visit. So when you're meeting with the staff, if there's something new that came up, make sure they know about that. And bring a pen and paper. I always have pen and paper in the drawers of my office, and I can write something down for patients to clarify complex instructions, but it may not be the case when you're going to a walk-in clinic. So bring your own pen and paper, and I'll tell you what to use it for in a moment. So share your list right at the beginning when you're booking the appointment. Kind of prepare yourself before you call the office, and then share that information with the staff. Make sure the staff puts that information for the doctor to see, and that appropriate time has been scheduled, or more than one visit if it's multiple unrelated problems that can't be managed in one visit. And to make sure if anything has changed, to clarify that at the beginning of the visit. Otherwise, it might look like, oh, this patient should go through the express checkout because they only have under 3 items. But you would get really mad if you're the cashier at Safeway, or if you're the customers behind when that person that came up with 1 or 2 items actually pulls another 6 items, and they're really complex items that require staff to leave and to check on things and do special types of receipts, and you're slowing everyone down. But of course, medical care is even more complex than that. So don't try to get a quick appointment by saying you only have 1 problem and then surprising us with multiple complex problems, because you're definitely not doing the staff and the physician any favor, and you don't want the doctor to have to rush through your problems. That's how we make mistakes, when we're stressed and rushing. And finally, how to get your doctor, reminding your doctor to speak normal plain English. So if you don't understand the doctor, a lot of people are so polite and they won't tell us they don't understand. So sometimes we have to ask just to make sure that they have it down. And if it's a particular complex medical term, I like to write it down or print it out, or print out a copy of the report and highlight the details for my patients. So don't be shy to ask, because you don't have a medical dictionary at your fingertips either. So ask the doctor to write it down. But some doctors don't write very neatly. So if your doctor has messy writing, maybe ask the doctor to print it for you or type it out. And that is not time consuming, but it's really important, because it's really important that you understand, or that I understand you, and that you understand me, and we talk together to negotiate what you'd like to do about the problem. So these are key things that you should know for any treatment. Like if I referred a patient for physiotherapy, what they should know about it, or if I wrote a prescription, these are some key things that I would want my patients to know, even if it's some antibiotics. So these are the four key things that you should know about. And if they're not addressed by your doctor or healthcare provider, then you should ask for it specifically. And that's why it's kind of nice for you to print out the key points handout, because it's right there. You can show it to them. And one of my colleagues said that my patient read in the article that I should ask you these questions. And then my colleague tried to make a joke and telling his patient that, oh, Dr. Wong was just joking. But I'm really serious. These are really things that you should know from any physician, emergency specialist, walk-in clinic, or your family doctor. If we recommend a colonoscopy, these are the key things we would want to answer for you as well. And if it's an X-ray or a CT scan or MRI, these are some key things that we should explain to you as well. So number one is, we call it indication, but what is it for? What's this treatment for? What's the prescription? What's the condition it's supposed to be treating? So you need to know that, because so many people are on multiple drugs and don't keep track of which one is for what. So if you have like 5 different medications you take all the time, and you're not quite sure what they're for, don't be shy and bring them to your doctor so you can write down what each medication is for. And then number 2 is, what are the common risks or side effects of taking this medication? For example, if it's a particular antibiotic like ciprofloxacin for a bladder infection or certain types of skin infection, the patient knows what it's for, is to treat that bladder infection. But what are the common risks? As with all antibiotics, there's a slight chance of allergies, although that's not super common, and these are the symptoms of what to do about it. Most antibiotics can upset the bowel, can wipe away some of the normal bacteria that should be there, and then it can cause abdominal pain, gas, and diarrhea. And sometimes an antibiotic can wipe away some of the normal bacteria elsewhere and cause yeast to grow. So yeast infections are common with antibiotics as well. And a lot of medications can cause nausea or fatigue or headaches as well, that we should relate to as well. But then what are the major risks? So major risks could be a severe anaphylactic reaction that requires you going to the emergency. That's extremely rare, but that's possible with any medication. A rare but important side effect of Cipro is that it can increase your risk for getting tendon injuries, like an Achilles tendon rupture. So I kind of warn patients, if they're young and athletic, and I prescribe ciprofloxacin to them, I tell them they shouldn't be jumping around or sprinting during the time they're taking the antibiotic, because that can result in some tears of muscles or tendons. And then the fourth question is, what are the alternatives? What's something else that I can use? And is that reasonable to do as well? Like, would just taking cranberries or cranberry juice help treat my bladder infection instead of taking the antibiotic? So briefly, what the other choices are. So if you have this information, then you're in a better position to make an informed decision, what we call consent. You consented to taking this. If you don't know what it's for, you weren't told what the risks are, and you have risks and side effects and bad outcomes, then it's pretty clear that you were not given enough information to provide consent. So that goes for any type of treatment, including prescriptions, surgical procedures, and any particular investigations, especially if they're invasive, like biopsies. In particular for drugs, you should know what it's for, but you should also know what the interactions are. So if they interact with food, then we want to tell our patients about that if it needs to be taken at a particular time. Will it interact with other medications you're taking? So some antibiotics like erythromycin or Biaxin gets metabolized by the same liver enzyme that a lot of other medications are, including particular cholesterol-lowering medications. So if someone's taking a statin like Lipitor and they're prescribed Biaxin, we would ask them to stop their Lipitor if it's safe to do so during the time they're taking the Biaxin. So we need to inform patients if there are potential serious interactions with drugs or with food. You should know two things about the drug you're given: the brand name and the generic name. The brand name is kind of like your first name, the generic name is kind of like the last name, but the generic name is the name of the molecule or compound. So for the blood pressure medication Norvasc, which is a brand name, the generic name is amlodipine. So we might prescribe Norvasc but allow substitutions, and your actual drug is amlodipine. There are many generic drug companies like Taro or Mint. So those are added as prefixes before that generic name on your drug. So don't try to just remember the first 4 letters of your drug, because that's probably just the generic company that makes many, many hundreds of drugs. So if you're not sure which is the generic and brand name, ask the pharmacist or your family doctor so they can highlight that for you. It's good to know both if you are taking the brand name, but the generic name is most important. But even more importantly is that you know the dose. Not just one tablet, but what size is that tablet? Is it in milligrams, micrograms? And how often are you supposed to take that medication, those capsules or pills? Is it twice a day or once a day? So those are the 4 key things in particular you need to know about any drug that you're prescribed: what it's for, what it might interact with, either food or other drugs. You should know the brand name and the generic name, the molecule name, the dose, usually in milligrams, and the frequency, how often you're going to take it. So those are key things to know. They're right on the label, but we can show you how to read those labels. And if you're seeing a doctor that you may not see again, who might just see you one time, and you're worried that the specialist or this walk-in clinic doctor, emerge doctor, might have the wrong diagnosis, these are 3 questions to wake up the doctor. Because when we're seeing a patient, we always have this funnel approach. The patient presents symptoms or signs, and then based on those symptoms and signs, we're trying to figure out what is the diagnosis, what could this be? And at the beginning, we start off really broad, and then we narrow like a funnel once we have more information from the physical exam and your responses to different questions. So if a doctor is in a rush, you might funnel too quickly and kind of force the diagnosis for the abdominal pain and assume that it's the gallbladder. I'll give an example. I had a patient, this was quite a few years ago, about 20 years ago, maybe 15 or 20 years ago. My patient had a colonoscopy at another hospital. And immediately after the colonoscopy, she had a bit of a sore throat. She's a bit short of breath. And she told the nurse I was looking after her, and she said, "Oh, it's probably getting a little bit of a cold." So the treating doctor wasn't informed. So that evening, the sore throat was worse, so she went to the emergency. And it looked like the emerge doctor was in a rush and kind of funneled too quickly and said that she had strep throat and gave her some antibiotics, which is a common cause for sore throat, but that's not actually what she had. And I saw her the next morning, and as her family doctor, I knew that she had had a colonoscopy. And I knew that the worst case scenario with a colonoscopy one of the worst case scenarios would be perforation of the bowel. The scope or probe kind of punctures the bowel and causes air to leak out and bacteria to leak out as well, from the intestine into the abdomen. So I did a careful exam, knowing that, felt over her abdomen, listened to her chest, and looked in her throat, and felt around her neck where her throat was sore. And around her neck, I felt some crackling. We call it crepitus. And it was subcutaneous crepitus, the feeling of air underneath the skin. So I knew right away that the most likely diagnosis was that she had a complication from the colonoscopy. Air had leaked from the bowel. It had seeped underneath her skin, up the abdominal wall, the chest, and up around the skin around the neck. This caused a sore throat. She was in danger of sepsis, overwhelming infection, and death. So I immediately sent her to Burnaby Hospital, and she was treated by one of the surgeons that I know and trust. She had a partial bowel resection where she had a perforation, and she remains healthy today. So it's good to know these 3 questions to ask the doctor with any symptom. What else could it be? So what else besides that diagnosis of a strep throat could this be? And what's the worst thing it could be? In this case, it was a perforated bowel from a colonoscopy. And what would you recommend for your mother, your father, your child, depending on your age? So that gets the doctor to open up his mind. What else could it be? Then you're just making sure that you've thought through these questions carefully and ruled out all likely possibilities, and also ruling out things that are less likely but are really serious that it could be. And then finally, making sure you treat your patient as you would like your best friend or family to be treated too. So that same degree of care and deliberation. So 3 awakening questions you can ask any doctor. My patients don't have to ask me this. It'd be kind of insulting if you do, but if you just saw the webinar and you see it in the next week, I know it's a joke. Because I ask myself these questions all the time. So the other challenge in communication is, of course, doctor's orders or patient's goals. So I learned early that I have to listen to the patient and make sure I know what their priorities are and check things out. Is it okay if we do this or that, or recheck this or try this medication? Do you feel comfortable with that? And what might be the barriers to doing that? But you're the one that should choose your goals. You want to choose a goal that's important to you. So if I chose your goal, then that's not appropriate because I don't know your values more than you do, and I don't know what matters most to you. It's really important to visualize yourself achieving that goal because you're kind of priming the pump, your subconscious, for success. Because there's a truism in modern neuropsychology is that what we focus on, we amplify in the brain. So we focus on achieving our goal rather than the problem, we're more likely to achieve that goal. We can start creating steps towards that goal. And that's my next step. Break down that really big goal of doing the sun run, if you haven't even been running, to a molehill, which is just start doing a walk and run for 5 minutes this afternoon. So make it really doable and manageable so it's not overwhelming or likely to get you injured. And then once you gain confidence in doing that little goal of walking, running for a couple of minutes this afternoon or tomorrow, and feeling good doing that every other day, the next week you can move up something more towards the mountain, but not quite unattainable. So increasing the number of minutes, increasing the number of minutes you're going to be jogging as well. So just increasing your goals just to match your confidence, and your confidence will grow. Write down what you want to do, because it's been shown that if you write down your goal, you're more likely to achieve it. And even more importantly is to share it with other people too. But what do you write down first? You want a SMART goal. So in Burnaby, we have SMART test goals. But a SMART goal is specific. You have to say specifically what you want to do, not just to exercise more, but specifically what you're going to do for exercise and where you're going to do it. M is for measurable. So how often you can, how much exercise you're going to do, how long or how far you're going to walk or run. A has to be achievable, realistic and doable, like breaking that mountain into a little molehill that you can do really easily. And R is relevant, important to you and your health. It matters to you. And T is time. When are you going to start? When are you going to finish? And when you're going to review things? And of course, in Burnaby, we have the smartest goals. So we added E for evaluate. Check out how you did, how you feel, what are you going to do next? And S is stepping forward. What will you do next? And T is for team. Who are you going to share your success with? Who are you going to bring along to coach or to be your coach? So smartest goals. These are some of the keys to success. Be very specific with your goals. And as I mentioned, we always have to anticipate what might be the barriers that can get in the way of our goal. For example, it might be the goal of walking every day. So a day like today, when it's rainy and windy and dark, what will you do to keep up with your exercise? So will you be walking in the mall instead? Or will you make sure that you have a safe place with a bright yellow raincoat and plenty of lights and reflective wear so it's safe for you to walk, preferably with somebody else? And then finally, enlist support, like a coach, or to be a teammate, a friend or neighbor, or your family doctor. The more support you have more people rooting for you, but they can be problem solvers for you as well. And when we declare our goals, our big and small goals to others around us, we feel more responsible for working towards and achieving that goal. So these are the key things everyone should have, what you should know about your medical history, and actually have it as at least a one-pager. So it's always with you in case you are at an emergency in another country or go to a walk-in clinic. So when I started practice, I also worked in a walk-in clinic until I had no more time outside of my practice. And it was a great way to meet new people. And I met a lot of my patients through the walk-in clinic that was attached to the practice as well. But I would always ask these questions, even if they're coming in for just a bladder infection. I would want to make sure I know what your allergies are, particularly to other drugs in the past. I need to know your family history. Is there family history of heart attack, strokes, diabetes, or cancer? And any hospitalizations or major illnesses or operations you had? And do you have any chronic medical conditions like high blood pressure, diabetes, heart disease or heart failure, asthma, and any prescription medications you're taking? It's also useful to have a list of vitamins you're taking and any non-prescription medications too. Because as things move from being prescription to being over the counter, there are a lot of potentially dangerous drugs that people can get over the counter, like ibuprofen or Aleve. Both are anti-inflammatories. Any of them taken for a long period of time can cause an ulcer. All of them increase blood pressure, decrease kidney function, increase heart failure. So they should have more labels listed on ibuprofen and naproxen that people can still get over the counter. And I really don't think people that are over 50 should be taking anti-inflammatories without consulting with their physician first, even though it's over the counter. Likewise with aspirin. So ask your own physician first before taking those medications. So know your allergies, your family history, major illnesses, operations, and hospitalizations, the dates and what the conditions were, and chronic medical conditions and your medications with those details about medications that we talked about. What it's for, the name brand, if it is name brand, or the generic name, the milligram size, and the dosing frequency. So if you don't have a family doctor, you should still make sure you get the screening tests you need. You can even go to a walk-in clinic and ask them for these specific tests if you're due for them. So on the Empowering Patients website, I do have this poster and this list and a talk on screening tests that you should take a look at. So screening tests are for the early detection of medical conditions with people that have average risk. That means no symptoms and no family history. If you do have a family history of a condition like breast cancer, you should talk to a physician about what type of screening you should do. If you have breast tenderness or a lump or nipple discharge, like symptoms that might indicate a breast cancer, you shouldn't do the screening test. You should see a physician and get a diagnostic mammogram or ultrasound, depending on the circumstances. So screening tests are designed for people with no symptoms and average risk. And those with family history need to be screened in different ways. And people with symptoms should be given diagnostic tests by their physician. So for blood pressure, the guideline is a blood pressure measurement in all adults at every appropriate medical visits. And this used to be like about once a year if we haven't measured it on patients that come in, but now not even 60% of our patients are coming in person. So if there's any potential family history or risk factors, I often recommend a home blood pressure monitor. But all adults over age 40 should know what their normal blood pressure is. And all adults over 18 should have their blood pressure checked at least every 1 or 2 years, particularly if there's any change in their health status. So you could check at the drugstore, but if the number's at the line, then you should get it checked in a medical office or clinic. So cervical cancer is screened with pap smears, and for women that should be done between ages 25 and 69. So if a woman is over 70 years old and all her previous 3 pap smears were normal, then they can actually stop doing screening. And usually the cancer agency indicates that on the pap smear report that they can stop before they're age 70. The pap smear reports also tell us if that needs to be repeated like in a year or 6 months, but if it's normal, it's usually repeated every 3 years. And so if you're overdue for your pap smear and you don't have a family doctor, you could get this done at a walk-in clinic. Screening for diabetes actually is a kind of a complex online risk calculator. You can use the CAN risk calculator. So people at high risk should be checked every 3 to 5 years, and every year for those at very high risk. An example of very high risk is someone that has a strong family history of diabetes in a parent or a sibling, or if they've had gestational diabetes in their pregnancies, then they should be screened every year for diabetes. And other things that increase your risk for diabetes would be other chronic conditions as well. In the past, we often would kind of review things and people are over age 40 with no family history. We talk to them about when is the appropriate time to screen for diabetes. And there's 2 tests, either a fasting glucose test or the hemoglobin A1C, which is a measurement of the percentage of sugar attached to red blood cells, which live for 120 days. So it kind of gives us an average of sugar control over the previous 2 to 3 months. With breast cancer, screening mammogram is recommended for women 50 to 70, although for my patients, screening used to start at age 40, and the mammogram program is open to women age 40 to 70. I usually recommend my patients start at age 40, and it's recommended every 2 years. If you have family history of a first-degree relative, like a mother or sister that had breast cancer, then we generally screen earlier. So talk to a healthcare provider about when you should start screening if you have family history. And screening could stop at age 70, but when I have healthy patients, I often write them a letter so that they can continue screening mammograms if the early diagnosis of breast cancer would have a significant improvement in their life expectancy. So if a patient is really frail and old and not likely to live for another couple of years, then they might forego doing the screening mammogram if they're over 70. But if the patient is in really stable, good health, it would be useful to diagnose breast cancer because the risk increases with age. So a doctor can write a letter or a note that the patient can bring to the screening mammogram clinic so they can continue beyond age 70 if it's appropriate. And colon cancer right now in BC is generally screened with the FIT test. So it's a test that takes a little tiny sample of the stool. You don't drop it, you don't do the number 2 at the lab, you do it in the comfort of your home, but you bring home a little kit where you can just take a little tiny sample, very small sample that's not contaminated with water. So the FIT test is done every 2 years. It used to be every 2 or 3 years, but the system is set up for every 2 years. And it can be linked up with the cancer agency so they can remind you or send you the kit as well. An alternative is a colonoscopy every 10 years, but the way that the system is set up in BC is people cannot just go see a surgeon and get a colonoscopy without any family history or history of polyps or blood in the stool. You would have to do the FIT test. So the FIT tests are every 2 years. If a FIT test is positive or a patient does have blood in the stool, then they're referred for a colonoscopy. And this is for people at low risk with no history. If people have had a colonoscopy and particular types of polyps are found, then the screening for a colonoscopy is no longer a screen, but a surveillance colonoscopy, generally rechecked in 3 to 5 years to make sure no new polyps have grown. And the usual prostate screen, the classic, is the digital rectal exam, and it's not high tech, it's digital meaning finger, the gloved finger of the doctor. And generally we do this for men that are 50 and over, particularly if they have symptoms of an enlarged prostate, which is usually benign. But there is a blood test called the PSA. Hasn't been recommended or paid for by MSP as a screening test, but it is recommended by physicians and including urologists, that it is a good test in people that are healthy over age 50. And if a PSA is markedly elevated, it should be interpreted in conjunction with the digital rectal exam as well, to see if it's just from an enlarged, very enlarged prostate, or there could be a nodule or potential prostate cancer. So prostate cancer could be screened with that blood test in the appropriate individual, but may not be appropriate in someone that doesn't have a long life expectancy, like a 90-year-old that is in frail health and not likely to live for another few years. Then a PSA might be inappropriate because it might warrant a lot of invasive investigations that may be harmful to the patient's health. So health is not about treating problems, and it's not about treating disease. I think of health as the optimal balance of the important areas of your life based on what you value and where you find meaning. So it's very individual. And I think health and one of the purposes of our life is to achieve our positive potential, to being the best that we can, the best possible life, best version of ourselves. Now, those important areas of your life could be your work or your recreation, your favorite sport, like paddleball. It could be your family or your friends, your social connections. It could be emotional well-being, a healthy environment, your physical well-being, or a well-balanced mind and learning new things. Another important area can be your financial well-being. Another is your spiritual well-being. And work must balance with rest and play and recreation. So these are all important areas of your life, and it's important to note what your goals are in each of them and what your values are. At the center of it all is our calling, what really charges our battery. And for a family physician, it's really caring for people as people and not treating disease. It's listening carefully and helping our patients achieve their positive potential in life, to improve their relationships, to teach them skills so that they can manage stresses, and to guide them through a complex healthcare system, to help them achieve both emotional, social, and physical well-being, and know that they're not alone, that we're all part of a greater whole, and that one of our purposes in life is to achieve our positive potential, but also help others to achieve theirs. So imagine that, achieving your positive potential, visualize that, what that might look like. And imagine sharing what your skills and your knowledge with other people so that we can all create a healthier community. And just remember, treat everyone, even if you're not a family doctor, as you would want a family member or a best friend to be treated as well. And remember that healthcare is self-care, but we're here to partner and support you in being your best self. So I think I'm finished with a bit of time that we can answer any questions that you have about what we've talked about today, or any other burning questions, as long as they're not personal medical questions that you'd like to speak to a healthcare provider that knows you best. So I'd like to invite Leona back on to share any questions or
Hello.
comments.
Sure. Actually, I have a couple of questions for you. Craig said during previous webinars, you've discussed whether or not you would go to an event like a Vancouver Canucks game and what precautions you might take. What would you do now?
Well, I probably wouldn't bother going to Canucks game because I'll probably lose. And I get just excited when they are starting in the lead. So I probably wouldn't take that risk of getting COVID or a man cold again by going to a game. But if I did have to go because of some obligation, then I would wear an N95 mask and I wouldn't take it off even to have a snack or a drink.
That's a good answer. What can be done and is being done to help lower the administrative burden on family doctors?
Well, the Ministry of Health and the Doctors of BC are in the midst of negotiations. So it looks, this is the closest we've been for them actually really looking at the specific problems family doctors are facing. And it isn't just the fault of the Ministry of Health. It's actually a variety of things that have combined to make it really challenging and difficult. Some specialist office make us duplicate a lot of work and download a lot of work onto our staff to do investigations or do things for our patients that they should be doing with the referral, or making it difficult to make referrals or making us write multiple letters or rejecting referrals. So that's part of it. So specialists and specialist office not valuing our time. And it's other things would be like companies, insurance companies that have very complicated forms that don't really suit the patient's condition, that demand notes for work. If you're going to be missing a couple of days, that requires you to come and see your doctor and have the letters written. Of course, that's quite appropriate if someone is taking a lot of time off and they're not sure if they're really sick. It could be appropriate, but that's a big burden, more insurance forms than before. And just that understanding that we do this because we really care about and love our patients. We love helping people achieve their potential. We don't like to see people sick, but we're there to support people emotionally and socially through the toughest times, even in palliative care. And that we're here for the long haul. So please thank your family doctor that's been looking after you, and encourage him or her not to throw it in, and check in on them to make sure that they're not really burnt out as well.
That's great. Well, I don't see any other questions, just a lovely note from Tanya in the chat for you there, Dr. Wong. We have in past, some of you may know, we used to do these talks in person. Thanks to COVID, we've been doing them online, but we do actually have a quick poll for those that are on about just whether or not you'd be interested in doing these talks, attending them in person. So I'm just gonna pop up a quick poll. Hopefully everybody can see it. And if you could just answer the poll for us, just to give us a sense of whether or not we should just keep doing them on Zoom, or should we explore doing them out in the community? So thanks. I'll just give it a few seconds here. Thank you. Any more? Another 10 seconds. Anyone else want to answer? We've got 12. Okay, I think I'm just gonna call it. We have 15 folks answer the poll. Thank you very much. And it was pretty much 50-50. So Dr. Wong and I will talk about that offline and see if maybe in the spring we can, when the weather's nicer, we can do it in person. That's it for me, except that when we stop the stop the Zoom, a brief survey is going to pop up. Just gives us a bit of some information about how we plan the talk. So if you would take a couple of seconds to do that, that would be great. Anything else from you, Dr. Wong?
Thank you very much for attending. I know you There's lots of great TV shows on that you could be watching and spending time with your loved ones. But thank you for spending the time with me. And I really love being a family doctor, and I don't plan to retire anytime soon.
Well, that's good to hear. Everybody's happy to hear that. Thank you. Be sure to sign up for our upcoming talks, folks. We'd love to see you. Have a nice night.
Okay, and thanks, Leona, for all your support.
Thanks, Dr. Wong. Take care.
Take care.
Good night.